Hello, today I will be discussing pediatric patient assessment and management as it pertains to flight nurses in the Air Force. This presentation will cover these topics. We will begin with vital signs. The heart rate and respiratory rate normal ranges are listed on this chart for neonates to adolescents and should be counted for a full minute. The neonate vitals are not listed in AFI 48-307 Vol 1, but it is important to know if you have the misfortune of having an unexpected delivery during transport or have to transport NICU babies. The average systolic blood pressure for children 1 year or older can be calculated by taking the age in years, multiplying by 2, and adding 90. The lower limit can be calculated the same way but adding 70. However, that number would indicate hypotension and immediate intervention would be needed. For funsies, I've included a chart that lists the BP norms just for your information, which comes from the AHA. Since pain is the fifth vital sign, determining if PEDS patients have pain and how severe it is not as easy as it is for adults. Depending on their age, they will not be able to give you a number rating. Two pain scales have been adapted for PEDS, the Wong-Baker FACES scale and the FLAX scale. The Wong-Baker FACES scale can be used for patients ages 3 and above, and the FLAX scale can be used for patients between the ages of 2 months and 7 years or individuals that are unable to communicate. Here are the stresses of flight that can affect pediatric patients. The first stress of flight is decreased partial pressure of oxygen. Infants and younger children are more reactive to hypoxia and will become hypoxic earlier than adults. Cyanosis is a late sign of hypoxia. The second stress of flight is barometric pressure changes. Encourage the use of a pacifier or bottle on descent to help clear ears. If diaphragmatic movement is restricted due to gastric compression, consider elevating the head and decompression with an oral or nasogastric tube. The third stress of flight is thermal. Thermal changes have the greatest impact on infants and young children due to their sensitive thermoregulating system. Consider increasing the cabin temperature if necessary and possible. The fourth stress of flight is decreased humidity. Infants and children are more susceptible to dehydration than adults. If an ALICE is being used, ensure that the proper amount of distilled water is present in the humidification sponge. If not NPO or receiving IV fluids or tube feedings, give fluids every 1 to 2 hours. The fifth stress of flight is noise. Infants and children are sensitive to excessive noise. Earplugs should be cut in half vertically to fit smaller ear canals. Even for infants in an ALICE should wear earplugs. The sixth stress of flight is vibration. Ensure if infants are padded when they are in car seats or the incubator, and ensure they are secured snugly to not allow extra movements that increase this vibration. The last stress of flight is fatigue, which has the greatest impact on pediatric patients between newborn and 12 years old. Moving on to assessment, there is a systematic approach to identifying life-threatening conditions that are not cardiac arrest early in pediatric patients. Using the pediatric assessment triangle and in transitioning to primary then secondary assessment using PALS guidelines. You perform each step and intervene before proceeding to the next. Begin by getting the initial impression. Assess the appearance of the child. What do they look like? Are they acting normal? What is their level of consciousness? Then move to their breathing. Are they having difficulty breathing? Is there wheezing, stridor, or grunting? Then move to circulation. What is their skin color? Is there any bruising or bleeding? You evaluate, identify, and intervene as appropriate as you move along in your assessment. In a situation where you have to intervene for, let's say, a lethargic and pale child that you have just assessed, you follow hypovolemia protocols from PALS, which is 20 milliliters per kilogram bolus over 5 to 20 minutes. In the rare event that a pediatric patient sustains a burn in flight, get orders to begin fluid resuscitation, and if the child meets the rule of tens criteria, that formula would be used unless determined otherwise by the flight surgeon. It's also important to keep in mind that pediatric patients have different body surface area measurements depending on age. And make sure all peds patients be placed on IV pumps when given fluids. Another emergent condition that requires immediate attention is respiratory distress and respiratory failure. Respiratory distress is a respiratory rate of over 60 per minute with grunting or forced expiration and head bobbing. Sternal retractions and obvious chest muscle pulling and nasal flaring are seen. The patient will have poor peripheral perfusion, tachycardia, and altered mental status. Respiratory failure is a respiratory rate of less than 10 per minute and or irregular respirations. They will have a slower than normal heart rate with weak or absent pulses, hypotension, and most likely be unresponsive. Immediate treatment is 100% oxygen via non-rebreather mask or blow-by if not tolerated with oral or nasopharyngeal airway. If the breathing is ineffective, consider rescue breathing with a bag valve mask at the rate of 1 breath every 3 to 5 seconds, or endotracheal intubation per PALS guidelines. If patient is hypotensive and capillary refill time is slow, fluid resuscitation will be necessary. If patient becomes bradycardic with hypotension and altered mental status, CPR will need to be performed. In the event of cardiac arrest, PALS guidelines will be followed. In contrast to adults, cardiac arrest in peds does not result from a primary cardiac cause. It is typically the end result of progressive respiratory failure. With the current BLS PALS guidelines, cardiac compressions start as the first intervention and then advanced airway preferred and giving 1 breath every 6 seconds. A Braslow tape is used to quickly determine the sizes needed for equipment and weight-based medications without calculations. Refer to the PALS pediatric cardiac arrest algorithm for correct procedures and guidance. Because unplanned deliveries can occur, newborns have to be considered as part of our pediatric population as well. Immediate actions after delivery includes drying and stimulating them, suctioning their mouths, then their nose if needed, clamping the cord and cutting it, and then placing the newborn on the mother's abdomen underneath a blanket to regulate temperature. Then, congratulate yourself on a job well done and getting a new patient. A new 3899 or EHR record needs to be created, and the patient needs to be added to the patient manifest. Documentation includes the time of birth, APGAR scores at 1 and 5 minutes post-birth, and that no vitamin K and eye ointment was given. Make sure to also fill out the 3899 cover sheet and fill out a patient near-miss form. And again, this is what we have covered. Thank you for listening, and if you have any questions, please see the chief nurse.